Good evening all. Welcome to Yashoda webinars series. Today's topic is trauma radiology. We have our speaker, Dr. T.S. Srinath sir. He is a group head for all emergency departments of Yashoda Hospitals. I am Dr. Ranjith Kumar. I am the heading the Department of Emergency at Yashoda Somajiguda. So as you all know, trauma is one of the leading causes of death and morbidity in all over the world, not only India, but all over the world. Unfortunately, we are seeing the rising trend every single day with recklessness and carelessness, and many people are losing lives. So when a person is affected with trauma, it is not only the person who is affected, but it's the whole family who comes onto the road. We have seen many families who have displaced their livelihood because of trauma. And when this trauma comes, the ED activates like in a snapshot. So once the trauma comes, we have to have an actual protocol on how to assess the trauma, how to deal with trauma. Is it a polytrauma or a simple trauma? So we have a ATLS guidelines. So primary survey, ABCDE, secondary survey, 32 trauma and history, and investigations further. So now, apart from the, when you do your primary survey itself, you have to know which organ is involved, which you will know by knowing the mechanism of injury. Okay, so once you know the mechanism of injury, you know the injuries which are expected and how to diagnose that. Accordingly, you will write a list of the investigations what you want to do, and then you go about and do them. So today, Dr. Srinath sir will talk about that trauma radiology, what is important, what to look at, what not to miss. Things. Sir is a group head for emergency medicine, Yashoda Hospitals, Hyderabad, as I told, and is the treasurer for IFM and ACM. And sir, over to you, sir.
Thank you, Ranjit. It's very nice to hear from you. Sorry for the delay of 3 to 4 minutes. It's always a pleasure to be in front of you all, and it's very nice to see young and energetic residents who have all logged in and those who are going to log in. Since it's a very, very important topic, as we all know, trauma is we are number one in trauma deaths across the world. And trauma is actually, I would always say that trauma is the most pandemic than any other illness in the world. Because day in and day out, as I am speaking now also, there is a death because of trauma every 3 to 5 minutes. That's what they say in our country. And as per the census last year, we had almost like 6 lakhs. Officially, there were injuries because of traumas across the country. So that is how it is important. And every minute and every second counts when you are treating a trauma patient. This does not suffice that you should not break your rules from your ABCD, that is airway, breathing, circulation, disability, exposure, and go ahead and do of the radiology part. And as we all teach, as per the ATLS or NTLS guidelines, what we are going through, it should be important that each one of you should take care of the airway first. There is no question of changing the protocol of ABCDE. Along with that, only you have to continue. Once you have resuscitated the patient, only then you have to subject the patient for radiological procedures or radiological investigations. And each patient which comes into the emergency department, once you have done your homework of your airway, breathing, circulation, disability, exposure, then you submit the patient to relevant investigation. Let it be an X-ray, let it be a CT scan, or let it be an MRI scan, or any other sophisticated procedures like contrast enhancement, all these things, except for fast scan, which we do along with your circulation. Or when it is an indicator that you think that this patient is in tension pneumothorax, only then also you are being advised to do the procedure first and then take the X-ray later on. So this is how the management protocol goes on as per the ATLS guidelines. But what is important for us is looking into all these things, what next? After all these things, way beyond, because we are emergency physicians, we should know what next we have to do, how to stabilize the patient, what things we have to do next. That is the thing. So the progressive use of contrast enhanced CT allowed for a better section. Like I'll give an example. We had a patient, polytrauma patient last week. So there was a dilemma whether this patient should be proceeded with the normal CT or contrast enhanced CT. But we went on and did a contrast enhanced CT, and we could see that there is a difference between plain CT and a contrast enhanced because there was a splenic rupture. So we could subject the patient directly to the OT, take the patient onto the table and save the patient. So that is how it gives the motivation to us to look into, and that is the way we are going to reduce the life-threatening injuries which are important in the management of the patient. So each one of you should understand when you have to subject the patient and what kind of an investigations you want to do for these patients. Next slide, please. So multi-trauma patients, any patients, I would like to suggest you many times what we as clinicians do is, I want CT, I want X-ray, I want MRI. You want it, but then you have to go back and check it also. What kind of an illness it is there? What kind of a X-ray is showing you? You have to document it, what it is there. Only when you document it, you will be completing your way documentation, because today we are all liable, and documentation will save you. Without documentation, nothing is perfect in our emergency medicine practice. So you can see in this X-ray how clearly you can see, because the problem here is whether you are going to differentiate what the diagnosis is, and you ordered for a chest X-ray AP view, and you are going to see whether this is a pneumothorax or flail chest or whatever it is, and whether there is widening of the mediastinum also. So these are the things which will be helpful for you, and look into what you have to do for these patients. Especially when you're seeing a chest X-ray, please concentrate yourselves. In my further slides, I will tell you what you have to do whenever you're looking into the chest X-rays. Next slide, please. So then again, you see there the pelvis examination, pelvic fractures, because these are the things you have to clinically pick up the patients. Once you see for the compression test, don't do if it is compression positive, then do the distraction. No, only when there is a compression test positive, immediately pelvic binder should be applied. And then when you subject the patient for the pelvic X-ray, AP view or the lateral view, whatever you want, see what are the injuries you see. There is a pelvic ramus fracture, there is an inferior ramus fracture, and also these things. The other thing is the gaping of the pelvic bones. So if the gaping is more than 3 to 5 centimeters, then it is an open book fracture. Then you have to suspect that there will be more of bleeding. Then you have to activate the multiple transfusion protocol. So once you activate the multiple transfusion protocol, your blood will rush in. And then that is the way you have to keep thinking, what next, what next, what next. When the patient's blood pressure is coming down, the best way, always keep in your mind, do your IVC diameter, whether this is collapsing or not. And then second thing is expect the amount of blood loss. Now you see this X-ray, how much is the blood loss? We all know it can be more than 50% of the body's blood. So that means that you have to replace the blood. Don't replace with fluid, which is dangerous again. So blood loss, you have to replace for the blood, and try to mobilize these patients early to the OT, which will be helpful for the patient. Next slide, please. So what is the next thing is the lateral C-spine radiograph to detect the major C-spine X-ray, the major C-spine. See here, whenever you take a C-spine X-ray, most of the time what we see, it is between C1 to C5. That is not correct. C-spine means C1 to C7. You have to be visible of all the 7 vertebra. Only then you can be sure that this patient doesn't have a C-spine fracture. So if you are unable to extend, you should not extend. If the pain is there, if the patient complains of pain in the cervical region, don't try to extend his neck. It is always better to keep the patient onto the C-collar, subject him to the plain CT scan. That is the better way, because that is the golden rule, what you and me follow in the emergency department. So this is a low sensitivity, because always X-ray will not give you the fine this one. You can see here the difference between the CT scan and the X-ray. You can see there is a fracture here and a fracture here. But when you take a lateral spine X-ray, you may not be visible to see. And then you have to clearly image and then of course, today we have a portable CT which you can increase the image or decrease the image, but that doesn't suffice you, because if you see here, the fracture is somewhere here. So 1, 2, 3, 4, 5. So here, so sometimes this film itself will not come. And if it is a unconscious patient, and if he says that you are unable to exhibit the pain, then again it will be a problem. So that is the reason why sometimes you may mislead that the lateral cervical spine radiograph is normal. But the suspicion should always be there in a unconscious patient. At least in a conscious patient, you can rule out between both, whether it is there is a C-spine fracture, or you can apply your Canadian C-spine rule, or whatever you want. Next slide, please. So then the next important thing is here, FAST scan, focused assessment of sonography in trauma. What is the most beneficial thing, and what is the important of FAST scan in our emergency departments? Of course, we all do e-FAST today. We don't do anymore, only FAST, extended FAST only we do. The first and foremost important thing is you're looking into the free fluid in the abdomen. Not only the free fluid in the abdomen, when you do the e-FAST, you're also looking into the contractility of the heart, and whether there is a pericardial effusion or there is a pericardial tamponade. And also you are also looking into whether this patient has a pneumothorax, whether a patient has a hemothorax or hemopneumothorax, or even sometimes you can also see for the fractures also in the ribs. So that is how the ultrasound has made a vast difference. I keep telling that it's almost replacing our stethoscope when you see the trauma patients. That is how it has been utilized left and right in our emergency department. And if you are not aware how to use it, please make sure, if you don't have a machine in your department, that is always better. You go with the patient to the radiology, try to pick up all these small elements, how you can detect the free fluid, how you have to look into the pneumothorax, how you have to look into the hemothorax. That skills are a must today for all emergency physicians practicing. And what is the importance is, it is quick, it is easy. You need not manipulate the patient, because if you suspect a patient with a pelvic fracture, or you're suspecting a patient with a C-spine fracture, and you already got these investigations, or you have not got the investigations, it is easy to do a FAST scan and say that, okay, there is a free fluid in abdomen, I have to do something next. So that is how it has become a replacement for your stethoscope, and also for your diagnostic modalities, also subjecting these patients directly. Okay, there is a free fluid. Then plain abdominal CT may not be useful. So these patients should be subjected to contrast enhanced CT scan. So that makes a difference between your plain CT and contrast CT when you yourself do a FAST scan and say that, okay, this is what the patient has. Next slide, please. So the other important thing today is getting the CT scan. Timing of the CT scan is important. Once the vital signs have been stabilized, don't hesitate to get the relevant scans. That is important. Like what you see here in the plain CT scan of the brain, you're seeing the EDH, extradural hemorrhage, which is not crossing the suture lines, which is important for you. Whenever you see such a picture in your emergency department, that should alarm you, because extradural hemorrhage is the most problematic one than the this one, SDH. That is your subdural hemorrhage, because subdural hemorrhage can go beyond your suture lines, but whereas extradural hemorrhage will never cross the suture lines, and it will be constantly pressurizing onto the brain and constantly. So the midline shift is there, the ventricles are collapsed. That means that you are going to lose these patients. Sudden drop in GCS should always bring an alarm to you. Why this patient is GCS is dropping? So what is my next step of action? I have to take a CT scan of brain. I have to make note that whether this patient has a EDH or not. Immediately you have to call for the neurosurgeon. And if required, you can keep your parole set ready in your emergency department itself, so that the parole can also be done in the emergency itself. So that this is how it is becoming more and more useful for you to diagnose these patients. And then also see there how it is helpful. Once you stabilize the patient, take a CT scan, you see how you can diagnose a C-spine fracture or thoracic fractures or lumbar fractures, whatever fractures it is there. And also to diagnose multiple other fractures. So these are the things what we do in our emergency department, that is a multi-detector row CT or MDCT, which is more accurate to detect the fractures. We are not looking into the minor things, whether there is a nerve damage or a artery damage, but your first and foremost thing is whether this patient has a fracture or not. That is your foremost important thing. Later on, if the BP is not improving, if there is no improvement, then you have to keep thinking about vascular injuries. Because if you take 100% of the 100 patients, the requirement for the vascular injuries or a vascular thing will be 0.1%. That is all. So that thing, your decision making in the emergency department is very, very important. Next slide, please. So you have to know what is normal CT. Only when you know what is normal CT, then only you can tell what is an abnormal CT also. And many times what happens is, if the patient's GCS is low, you feel that the CT scan is normal. What else can be? What should you think of? Can anybody type in the chat box? What else other diagnosis? There is a normal CT of by your visualization. Your first year resident or even your second year resident may say, sir, the CT looks normal. There is no bleed. There is no midline shift. There is nothing else. But still the patient can always say, but still the patient's GCS is low. Then what? Yes, very good. DAI. That is diffuse axonal injury. So immediately your mind should go and say that this patient has a low GCS. I have to think about, because this patient has a diffuse axonal injury. What next I have to do? How can I go? So that brings you the confidence in treating these patients. Intubation, how you have to, what else you have to do it. And this is what you have to think and keep going on. Next slide, please. So I've already explained to you, this is a classical picture. What you see on a CT brain, that is extradural hemorrhage. You can see here, this is not crossing your suture lines. So this is important, because again, I'm stressing you, because many of us lose the patients if the patient is in the lucid interval. Suddenly, these patients will deteriorate. In front of you only, sir, GCS is 15/15, sir. Everything is normal, sir. But still the patient's GCS, immediately after 30 minutes, suddenly the GCS came down. So that thinking of yourselves, if you diagnose if it is a EDH, you should always keep on monitoring him. Only when you monitor him and constant neurological monitoring with GCS, with blood pressure, with heart rate, all these things put together, when you keep on monitoring these patients and then subject them to the right treatment, only then the patient's outcome will be good. So what is the moral of the story? Monitor the patient as long as the patient is in the emergency department. Today what I see is, everything is normal. We come and sit, we start writing the notes. After 15 minutes, the nurse will come and tell GCS has dropped. This should not happen. Whatever notes you have to write, please write it in front of the patient. Don't write away from the patient. So that you're looking at the patient now and then, and you are the best judge in that golden hour. What we all have to manage the patient in the emergency department. Next slide, please. So what do you think? So what is this one? The last one was EDH. SDH, very good. So this, everybody are in line with me. That's nice to see. So because, how did you say SDH? Because the whole bleed is across the suture line. It is not only keeping within the suture line, it is extending beyond the suture line. And you can see it is totally white in color. So it is an extended EDH, very good. So there is extradural hemorrhage, acute. Whenever you see the color, you should also know whether it is an acute or chronic or acute on chronic. These are the three things which you can see on a CT scan. Because in an elderly patient, regular falls can also be given as a SDH. So we have seen this one, you have seen this one. So it will be totally black. Somewhere there will be a white spot. That means that there is an acute on chronic SDH patient. What else this patient has? Rightly written here, it is also there is a midline shift. So always please calculate the midline shift. How much is the midline shift? Make an arbitrary line. How much the shift is there? more than 3 millimeters or more than 3 to 5 millimeters, it is a caution for you, alarm for you. You have to activate your neurosurgeon, say that, please, we need your support, because that is vital time which you have to. Whenever you're suspecting that the bleed is more, you get an alarm, you should tell the neurosurgeon that I need your support. Whenever the ventricles are not seen, whenever there is a opposite ventricle which also is compressed, that means that the alarm should be risen. So this is the important thing where an emergency physician plays in role. And even here also, keep ready with the burrow in the emergency department itself. If you're not ready with it, then you may lose the patient in the golden hour itself. So that should not happen to you. That should not happen to me. So you can see here again, what is there? I told you in the first this one, it is nothing but, what do you think? So what is a CT scan? SAH, very good. There is a subarachnoid hemorrhage. That is a ground glass appearance. So very, very nice to see all the answers. So here you have to monitor the BP. You have to keep the patient this one, and then you have to monitor for the GCS also. And then you have to submit the patient for a CT angiogram, whether there is a vesicular aneurysm, whatever aneurysm, or that part later on the radiologist will take care, because your role in the emergency department is your primary diagnosis and what is the subject, controlling the blood pressure, controlling the intracranial pressure, not allowing these patients into drop in the blood pressure, or not allowing the patient into losing the brainstem reflexes. These are the main important things which you have to take care in the emergency department whenever you suspect the head injury. So please be careful. That is what is a caution, what I would like to suggest you. Next slide, please. So what is here? EDH is over, SDH is over, SAH is over. Very good. IVH, intraventricular hemorrhage, and then there is also, this is also a cautious thing. So these are the things which you are very good to see. That is the way we have to be careful. We have to be ready with our answers, because when you communicate to the neurosurgeon what it is, you always a brief one. Tell the patient's name, tell the patient's age, and what is the GCS, what is the blood pressure, and what is the CT scan report. He will be very happy with you, and you are also good with it. These are the things which we all have to learn to teach our residents that, okay, this is how you have to communicate. Communication plays the key role between the emergency department and other departments. When you give this brief history and brief diagnosis, they will be prepared in the mind, and they will be coming out and say that, okay, this is what I have to do. So what is this one now? What do you think so? Any clues? Chronic SDH with midline shift. Anything else? So, very good. I could see good number of answers. That is the way we have to be, always be ready and tell. These are the patients also, based upon the GCS, based upon the clinical signs. You have to again activate your team and say that, yes, I have to call for the neurosurgeon, get the surgery done. Only then the patient will be ready enough. So the midline shift plays the key role. Next slide, please. So already it's been, the diagnosis is already put there. So we are left out only with intraparenchymal foci of bleed. So the next important thing is, you have seen all the bleeds. Now it's your intraparenchymal bleeds. You can see here how it has been looked into. Okay. So this is the way how you have to diagnose. That's the reason why I'm telling you, not only writing for the investigation. What is the diagnosis is the next important point which you have to tell and submit to the submit as your protocol. When you say all these things line by line, you will be confident to answer anything. You would be confident in your treatment process. Even then, some of the neurosurgeons will be, okay, I will stand beside you. Let your resident do the burhole. So that will be the confidence which will develop. Because many a times when I used to be there, I always request most of our neurosurgeons and say that, why don't you allow our people also to do the parole, so that our people will also get trained, because not every center may have a neurosurgeon, but treating the patient with these complications, treating the patients with STH, all these things is important to ensure that the patient gets the right treatment at the right place, so that the outcome is also right. Next slide, please. So what are you seeing here? You're seeing here what all the herniations, where it can happen and what it can be going through. So, and then what you have to be ready for. So that is how you have to keep in your mind. And this is an anatomical picture which you are looking in for, a gross anatomy, so that you know what it is and how you can be proceeding for. Next slide, please. So CT is always the first choice of imaging for any kind of head injury. We all know that. But decision making is important. The Canadian CT rule, especially for children with head injury. So this is the best way. Whenever the patient is having normal mental status, no scalp hematoma, there is no loss of consciousness, there is no non-severe head injury mechanisms, no palpable skull fractures, normal behavior, you can always wait. Please caution this. Wait. Wait is important. Okay, head injury is there, loss of consciousness is there, go ahead and do. No, you wait. Okay. And then normal mental status, no loss of consciousness, no vomiting, non-severe head injury mechanism, no signs. So this is how you have to decision making rules for avoiding the CT scan. So whenever when you are in doubt, I'm not telling not to do. When you are in doubt, you are the best person. You are the best judge in the emergency department to get the investigations done. Don't wait for anybody's application. Say, okay, please do this investigation. No, you are the best judge, because you are there. You are seeing the patient there. You are suspecting that injury. So you have all the liberty to raise for this particular investigation. Apart from that, when you can avoid is, please avoid, because it is nothing but you are giving the radiation that itself has its own complications. Next slide, please. So what are you looking for in the CT brain? You have to look for blood. Where you are looking for blood? So you are looking here, see, these are the blood. Then what you are looking for? You look for the cisterns. Then you look for the brain matter. Whether there is a shift, midline shift is there. Look for the ventricles, whether it is normal, whether there is a blood filling. Then look for the whole bone. Where are the fractures? So these things you have to keep in your mind, because ICP, intracranial pressures, Monroe-Kelly doctrine is very important, because all our heads are fixed structure. It cannot increase in size. Where will it increase? It will just herniate. So that should not happen for your patient. So keep in your mind, blood can be very bad, especially in this particular situation. In this particular situation, it's very, very bad. And when you have this, there is a midline shift, it is a very dangerous situation. Again, intraparenchymal bleed, shifting. See here, these are the dangerous things. Whenever you see again like this, skull fracture pushing the brain inside, again, that is also dangerous. So keep in your mind, when you have to be ready for your call to neurosurgeon, what you have to tell to your neurosurgeon. That's very important steps which you have to keep in your mind, and write it down before speaking to them. Write everything, document everything, so that you're not going to miss anything. Next slide, please. So again, for C-spine fractures, we all know C-spine is the best one to tell you whether this patient has a fracture or no fracture. But you and me, if you are speaking nicely, there is no complaint of pain, there is no tenderness, then why do you want to do CT? No need. Only when somebody complains of a pain, there is all these writings. But simple thing, what I always teach to my residents is, judge yourself. He's talking, he's speaking, he's not telling any pain. You are subjecting them to tenderness. There is no tenderness, then there is no point of doing a CT. Okay. Yes, if a patient complains of tenderness, if a patient is unconscious, if you are unable to rule out anything, blood pressure is dropping, CT brain is normal, then obviously you have to think about C-spine. Look into the C-spine then. Until and unless you rule out a C-spine fracture in an unconscious patient, don't take out your collar. If he is a conscious patient, then you decide whether this patient has to be submitted for C-spine, CT C-spine or not. Next slide, please. Next slide, please. Yeah. So whenever you're seeing a X-ray, what kind of a view is important? When you're ordering for an X-ray, again, what type of an X-ray you want? If it is cervical spine, what I want? I want AP view, I want lateral. When you're looking for a chest X-ray, either you can get AP view, either you can get PA view or dorsal view or lateral view. So which view you want? If he's unconscious, you cannot make him sit and take a AP view, correct? If he is complaining of pain, that is again you cannot. If a patient is normal, then you can always take a PA view. That is not a wrong thing at all. So that is how you have to think which modality of the radiology you want. Only then you will be successful in your getting your diagnosis also. Like what I mentioned, lateral view, when you see, draw a straight line and see whether all the vertebrae are in line anteriorly and posteriorly also. Looking for the pedicles, everything, whether there is any fracture, whether there is any dislocation here. Then look into the space between one spine to other spine, look into the space. If the space is normal, every spine, you have to look for the space. Because C-spine, if there is a space which is reducing, again, that is very dangerous. So these things you have to keep in your mind. Next. So again, continued. So you see here how you have to look in for. When you ask for a open jaw X-ray, then you have to look for what you're looking in for, not only the jaw, the C-spine also. So like this, you have to look in. See here, again, contour. Look into the contour also. Then you will not miss out any kind of a fracture. Next slide, please. So what radiological findings for a C-spine you can think of? So you can think of three things. One is compression, distraction, lateral flexion. You see here how it is. Again, in compression, it can be flexion, it can be vertical, it can be extension. Okay, that is what is compression fractures. Here, distraction, it can be a flexion distraction, or it can be a backward extension distraction. And then lateral flexion is again like this. So what are you going to look in for? Widened intraspinous space or the facet joints. These are the things which you are looking in for. Fractures means not only, okay, there is a fracture, that is not over. Because sometimes the pedicle fractures will not create anything. When you call and say, okay, to the spine surgeon, there is a pedicle fracture, he'll ask whether what is the flexion injury is there, extension injury is there, whether there is a compression on the nerves, all these things he'll keep asking you. So that is the reason why you have to look into the contour, you have to look into the fractures, look into the space, widen, reduce, anything. It is going front, going backward, slipping laterally, all these things are the ones which you are supposed to look for and treat the patient accordingly. And one of your colleague can always call and inform to the specialist who has to come and do the necessary surgery for the patient. So these are the things which you have to keep in your mind when you're seeing an X-ray for the C-spine. Next slide, please. So then again, thoracolumbar region. You see here the thoracolumbar, because these are the constantly missed out fractures. Because regularly we will not take the X-ray of the thoracolumbar. Only when you suspect, you will be taking it. But AP view of the chest can sometimes reveal you you have to see very, very carefully. Only then you can be perfect. But when you suspect that there is a thoracolumbar, any kind of a fracture, then please subject them to CT scan so that it will pick up and you have to see. You see here, what has happened here? The whole body of the vertebra is been burst open, burst fracture. Then next you see the here and here, the intervertebral space has increased. Okay. So these are the things you have to keep in your mind. This is about the fracture. Here you see there is a fracture plus dislocation. The vertebra has come forward. So these things you have to keep in your mind when you're seeing the CT scan and depict it and start the medications. Whether you want to start it, whatever protocol in use in your hospital, you can follow that one. Whether you want to give a steroid, don't want to give a steroid, that is written as per your hospital guidelines, continue the treatment. So this is about thoracolumbar spine. So here again you can see what is a compression, what is a distraction fractures, and then rotation fractures. You see here what is happening here. You can see the contour of it. You can see the contour of it. Once there is a loss in the contour, see correctly here, that is the important thing. The contour is lost. You have to immediately flare yourself and say that there is a compression fracture. See here, it has been marked distraction fracture. That thing you have to keep in your mind. Rotation, the whole spine has been fractured and rotated. So this again is important when you see your CT scan and decide where the fracture is, where the dislocation is, and then also trace the nerve involvement. Looking for the motor as well as the sensory as per the dermatome as it supplies. Then only you will be also looking in for fracture, dislocation, rotation, and then the neurological involvement. There is no neurological involvement, well and good. You have to immediately look in how this patient will not be subjected in for neurological involvement. What best you have to do, what things you have to do. So our motto in emergency department is make him immobilized by on spine immobilizer, or keep him in a neutral position. If you don't want to keep him on a spine board, that is not a problem. Keep him in the neutral position, place some bags or something, what it can help him not to move here and there. And you take care of the pain. Pain is the most important thing here. Analgesia. Don't hesitate to give analgesia here. Adequate analgesia is a must for such patient. If there is pain, then you will start jumping. Then again, there will be a nerve movement and the patient will go in for nerve injury also. That should not happen. Next slide, please. So now plain chest X-ray is important or not? Yes, it still holds good. If there is nothing called as nothing is important. Plain chest X-ray is an important, because until you stabilize a patient, you cannot shift the patient to the CT scan. So you do the for E-fast also, you can diagnose a pneumothorax, you can diagnose hemothorax also if you are an expert one. But sometimes you may miss out minimum pneumothorax, minimum hemothorax. So for that sake only, you have to take care of your, take a chest X-ray so that you're not missing the diagnosis. Because recently again, there was a debate in my department itself, whether this patient has a pneumothorax or not. So see, chest X-ray was showing a minimal pneumothorax. So we were always saying that, yes, there is a patient which has a minimal pneumothorax. So these are the things, because when you intubate these patients, because the patient GCS is low, what will happen? Patient will automatically go into tension pneumothorax. Should that happen to your patient? No, you should not allow tension pneumothorax to happen for your patient. So as a precautionary, you have to put an ICD tube. So that is the way you are going to avoid tension pneumothorax. If tension pneumothorax happens, what is the problem? Patient will go in for cardiac arrest. Reversible cardiac arrest is been created. That should not happen. So immediately, your motto is intubation first, followed by, if there is a person next to you who can put the ICD, simultaneously both have to be done. CT in only in severe cases or selected cases, whatever you want. When patient is properly not clinically evaluated, you have a doubt, you have done your CT, sorry, you have done your ultrasound, you have done your chest X-ray, but still you have doubt because sometimes mediastinum widening is there. Sometimes you are unable to detect the cardiac tamponade, pericardial effusion, sorry, not cardiac tamponade, pericardial effusion, you are unable to click it off, or sometimes aortic injuries are there. Sometimes some other injuries you may miss out. So for that sake, you can always subject them. And also you're suspecting the thoracic this one fractures. Then it's important for you to subject the patient to the CT scan. Next slide, please. So now the next important one, what I told you in my first few slides, whenever you see a chest X-ray, important thing is don't forget to write these things. Ensure that every patient, a column is there, chest X-ray column. If you go in for the WHO trauma protocol column also, there is a important thing. What is important? Every column, whatever X-ray you take, you have to know first details of the patient, whether you have taken the right patient and you're mentioning it. And then name, date of birth, sometimes date of birth may not be there. Film type, AP view or PA view, because the modality will again change. Then R is for right, that is rotation, whether it is an inspirator film or overexposure, all these things you have to look in for. Then soft tissues and bone. These first three things are very, very important. Then airway and mediastinum. In the breathing, what you're looking in for lung fields. Circulation, cardiac position, the border of the heart, so that you're not missing out any kind of a pericardial effusion, pericardial tamponade, all these things. Shape of the heart and the size of the heart. Because whenever there is an increased size in the heart, you have to keep alarmed. You have to think what is the problem. Then look for the diaphragm. So these are the important structures which we all know is in the chest. What other structures are there? That is the extras. You have placed an endotracheal tube. Where should it be there? That position T4, upper part of your T4. So that is important. Whether this position of the endotracheal tube is there, whether you have put a central line, whether it is there or not, whether it is kinked, whether it is not in the position. You have placed a nasogastric tube, whether it is in the stomach or not. PA catheters or ECG electrodes, all these things. Chest tube, so that you are looking into the lung expansion. All these things are very, very important. We'll order for chest X-ray, we'll say it normal. That is not the way. Go from lateral to the medial, or go from the medial, go to the lateral. These, when you document it for the first few patients, then it will become your routine to document it. If you don't document it, you are going to lose the patient. I'll write and give you. Because documentation will always be kept in your mind. You will never forget. This is this patient's X-ray. This is what is the PA view or AP view. How is the soft tissue looking? How is the lung fields looking? How is the heart looking? How is the thoracic vertebrae looking? Where is the endotracheal tube placed? That things, the contours. When you see a perfect chest X-ray, you may not require a CT scan. That is what I always keep telling. But many a times we take a CT scan also when we are in suspicion. But when we get a perfect chest X-ray with APR lateral view, that's very good enough to diagnose most of your deformities in the trauma patients. So because at that golden hour is important for you to place the tube or look into the patient and do the requisite things, what it is to be done. The 3 R's, right patient, right treatment with the right doctor. You are the right doctor, you have the right patient, and you are the right person to do the things which is required. So by large, we are emergency physicians. We should be on our toes. CT abdomen, whenever you suspect the abdominal injury, you kept a fast scan, there is a free fluid, you are unable to diagnose whether there is a injury or not. CT abdomen, contrast enhanced CT is always useful when you suspect for a patient with an abdominal injury. Even there are some studies saying that when you're doing a polytrauma series of CTs, include a contrast enhanced CT scan itself. So that may be the next thing what we may be seeing in our next future treatment protocols. So please, but only my request is resuscitate the patient and only then think about all these modalities of getting the radiological investigations. Next slide, please. Pelvis, of course, we can see only free fluid in the abdomen. Do a compression test, or when you take a pelvic X-ray, you may see the bony injuries, but you may not see the organelle injuries which are present in the pelvis. So, better to submit for a multi-detector row CT scan so that it has its own advantages. You are looking in for the whole abdomen as well as a pelvis in a single breath hold. So this is how you see the whole thing. You will not miss out any injuries. It will at least give you a suspicion. Okay, there is no pelvis injury. There is nothing, but still the patient's blood pressure is dropping. What suspicion you have to be kept in your mind? You may not be picking up with your fast scan. You may not be picking up with your pelvis X-ray, but still the CT scan can show something. What is that something? Retroperitoneal bleed. Very good. So retroperitoneal bleed, my friends, that can also be there. Your suspicion, that is why hypotension is still there. What next? Why should I take a CT scan? Retroperitoneal bleed. That is a masked one. That is why it is said that abdominal injuries are the one which can have sometimes more deaths. Mortality is more. Because suspicion, if you don't suspect, you don't do a CT. If you don't do a CT, you cannot diagnose. If you don't diagnose, you're not going to do the right treatment. So keep in your mind, suspicion. Emergency physicians should always suspect. Raise your alarm. Okay, why is the heart rate high? Why is the heart rate high? Why is the blood pressure low? I have done everything for this patient. I have done this. Where am I missing? Where am I missing? That should be in your thought process. Next slide, please. So pelvic bone again, I'm telling you, when you take any X-ray, look into the contours, inner contour, outer contour. Where is the fracture? You see. Does this patient requires a major, this one? May not require, because you can see both the pelvic bones, it is intact. There is no gaping. But still, the treatment is required. Isolated bone tears may be there, may not be requiring any kind of a treatment, but they may have to be placed on the neutral position. Let our orthopedic colleagues take the call whether this patient requires surgery or not. But for us, write the diagnosis. Isolated bone tears are there. Acetabular fractures with major functional prognosis. And then always, whenever you think that there is a high energy trauma, please don't hesitate. See for the gaping. Immediate pelvic binder. Don't even take all these modalities. Suspect pelvic fracture. Hypotension is there. Bring down. Gaping will always increase the bleed, and there is always mortality is very high. Next slide, please. So these are the classifications. I don't want to bore you. You all know that what are the things which can happen with the pelvic fracture. That is the AO classification is there. Anterior compressions, lateral compressions. Then again, that is type B1 and B2. Again, anterior compression. Type B3 and vertical shear, that is type C. So what you can see and what are the things you are supposed to do. Our important thing is whether this patient is stable, unstable. Unstable, what I have to do. That's what we have to think in our mind and keep it. But when you're writing an exam, that may not be sufficient. These are the things you have to learn and mention in your exam. Next slide, please. So then again, for the limbs, always it is better to take AP view, lateral view, and then you see where the fractures are. Look into the fractures. Sometimes there can be complex fractures, extension into the joint surfaces, or the main indications for the CT imaging, especially Sometimes what happens is shoulder joint dislocation is there. There can be a small chip which can be inside the bone. For that, you may have to rule out. Then you may have to take a CT scan. If the X-ray shows there is only a dislocation, it may not be required. When you see such things on an X-ray, you see here, there is multiple fractures here. See here, there is multiple fractures. All the fragments, there's a fracture. So these are the indications for your CT scan. Anytime you see two projections perpendicular to each other, innate extremity trauma, then CT imaging is a must in acute trauma setting itself. So that it gives you an idea what kind of an injury is there and what exactly the procedure is to be done for the patient. Next slide, please. Then sometimes what happens is the CT scan, the chest X-ray may be looking normal. Nothing, no fractures. There is no this one, but still the saturation is dropping. Then it should give an alarm. There's no pneumothorax, no hemothorax. The contours are good. There is no pericardial tamponade, pericardial effusion. The aortic knuckle is also good. There is nothing, but still the patient is having a drop in the hypoxia. Then you keenly observe the X-rays, pulmonary contusions. That is your next thing which you have to keep in your mind and say that, okay, this patient can have pulmonary contusions. Subject these patients for CT scan, no harm in it, so that you're going to pick up whether there is a hemorrhage or a contusion, what kind of a treatment it is required. Because again, you have to counsel the patient attendants, because if there is a pulmonary contusion, pulmonary hemorrhage, the length of stay in the ICU will be more, infections will be more. So you have to start your antibiotic early. So this is how an emergency physician should think in the emergency department. Next slide, please. So the CT of the same patient, you can see there is so much of issues. The pulmonary contusions you're seeing here. So that is how you have to subject what kind of a treatment is required for a patient. Next slide, please. So what is here? There's an arrow mark here. What is this? Anybody would like to take this? Is it normal or abnormal? Nobody wants to answer. Rib fractures, good. So rib fractures are there. Then you have to raise your alarm again that analgesia is important. So multiple rib fracture at multiple locations, what do we call? There is 2 or 3 rib fractures and it has, yes, very good. You are all with me. Flail chest. Nice. Nice to see the answers. Next slide, please. What is here? What do you see here? Pneumothorax, emphysema, collapsed lung bladder. What do you think so? I'm getting multiple answers here. It's a tension pneumothorax, friends. See this one, it is compressing, it is pushing everything. It is pushing the heart, pushing your mediastinum to the opposite side. So please, that is what I told you. Mediastinal shift is there, collapsed lung is there. There's the diaphragm is also pushed down. It's not emphysema, it is pneumothorax. It's very important for us to diagnose in the emergency department. Sometimes you may be confused. These patients may not be showing that they're going for impending cardiac arrest, but still there is a pneumothorax. Still keep thinking what it is. Okay, next slide, please. So what is this? Clavicle fracture, very good. Okay, so there is a right clavicle fracture. Only, again, I'm telling you why I'm showing you all these pictures is many a times chest X-ray means they'll take from here down. They may forget to take the cervicals, the clavicles. Sometimes they may include from here down. that is an incomplete film. A complete film is a one which shows both the clavicles with both the shoulder joints. Okay. So these are the reasons why I'm telling you, you have to keep in your mind. So I hope this class was helpful for you all. This is also there on our Facebook Live. So those who have anything, those who some of your friends who would have missed the class, they can go back to the Facebook Live and our Facebook, and they can also see there. And also in those Facebook also you can post your questions. You can also look in for. Thank you very much for listening. Any questions are there? Yeah, Anusha. I see two people raising their hands. Naveen, can you just...
Sir, one Anu D. Hegde is there.
Yeah, that's what.
In a two-wheeler RTA, if he suspected cervical fracture in a rider wearing helmet, do we remove the helmet before X-ray or CT to apply C-collar?
It is always good to hold in the inline stabilization, and the helmet should be removed in a just a small fashion, zigzag manner, and then take it out. The inline stabilization, 2 people are required. And then once the patient has been kept in inline stabilization, the other person should put the C collar, Philadelphia collar. You want to add something, Ranjith?
Nothing, sir. As you said, it's very carefully you have to do. But you are clinically suspecting there should be a cervical fracture, so you should be very careful in removing the helmet. As I said, inline stabilization is the one thing which do when you do any procedure. So inline stabilization comes from head to toe. It's just not the cervical spine. So you have to put head blocks, cervical collar, and straps on the body, and then tie the patient to the spine board. So that is the inline stabilization what sir is talking about. So any doubts? Any more doubts?
How to differentiate massive pneumothorax and hemothorax?
See, actually, sir, can I say this?
Go ahead, Ranjit.
See, first of all, hemothorax, massive hemothorax is a clinical diagnosis. If you are diagnosing that on the X-ray, that means you have missed it. Simple as it is. Okay, so it is in the clinical features when you're examining the respiratory system or the B, and you're in the B itself, you should be able to see there is a deviation of trachea and there is a raised JVP, all the signs. So it is a clinical diagnosis. And when you say how to differentiate massive hemothorax, see, pneumothorax is always it's air is like a jet black, like a outside of the ribs. How it is the air outside of the ribs is similar to pneumothorax, that is completely black. There is no lung demarcation, and it will there you can see a collapsed lung, and you should see the shift mediastinal shift also. But hemothorax, in contrast to it, it is white. White means white on the X-ray. Any fluid white on the is white on the X-ray. In that way, you can differentiate between pneumothorax and hemothorax. Hope this clears the doubt. Okay, fine. Anyone else? Any other doubts? Okay, you can also, as I said, you can also post your doubts on the Facebook page, and I think you can, where to reach us. And we have this webinar series every Friday evening, 6 p.m. to 7 p.m. Thank you all for joining us today. This was a wonderful session, sir, with a lot of education and a lot of learning points to take home for all the residents out there. And I thank Yashoda management, especially Pawan sir and Lingay sir, for giving this opportunity. Thank you, Srinath sir, for hosting this event. And Naveen for organizing. And thank you so much for all the back-end team. Without you, I think these webinars are not happening much. And thank you all so much. Meet you next week.
And you can subscribe to our future topics at the Telegram channel, and we'll be posting our links, recording links also on the Telegram channel. Thank you.
Thank you. Thank you, Naveen. Thank you, Ranjit.
Thank you, sir.